We'll get started. I think you're going to enjoy the presentation today, as you're going to start using some of the information you've learned to do some scenario planning. So we've got a combination of that and learning about types of revenue. And as I was standing here, I realized I kind of want to reorder the way I go through this, because I started with the fun stuff and ended with the boring detail, but I'm going to turn that around a little bit to make it more fun. So today is about revenue, which is really, really important. So you're going to learn all kinds of different theories and models of revenue and how we look at it. So this is from last time, and it is the revenue section of the income statement. And everybody remembers that revenue minus expense equals income. So the more revenue you have, typically, the more income you can do, and the better you can perform, and the more we can afford to spend on shiny new toys. Okay? So what we're going to do today is we're going to talk about all this stuff on the left side. Don't worry so much about that right now. But so we have gross patient revenue, which is charges, and then we have net patient revenue, which is our approximation of how much cash we're actually going to collect on that. And that ratio is measured here between those two numbers, the collection percent on net patient service revenue, which in our case is about 20 million, or 20%. Okay? I'm pointing out these numbers for a reason. If you look at this number, 486 million, that's for 10 months. So we're averaging about $48 million a month in net patient service revenue. Okay, and that's 20% of charges. And then we have these supplemental revenues, and here we have 26 million for 10 months, or about 26 million. Okay, so add those two together, we got about 74 million a month in revenue coming in. Everybody with me so far? Okay. Now, let's talk about revenue. So revenue itself is usually two numbers multiplied together. One is volume, and the other is the rate. Okay? So let's think about, say you've got 10 apples, and you sell them for $1 a piece. 10 apples times 1 is the rate, $10 of revenue, right? Okay. In our case, we have how much revenue per month? $74 million per month, okay? Now, we have all kinds of different types of revenue, and these are different revenue types, okay? And I'm classifying them by sort of how they work, all right? How they work, because not all revenue is the same. Not all apples are the same, all right? So the first type is called percent of charges. Okay, so in a percent of charge contract, patient comes in, we do whatever we do to them. Everybody puts their charges in, as they always do, with 100% accuracy. And all that shows up on a bill, and the bill goes to the payer, and the payer says, okay, I'm going to pay you a specified percent of those charges, okay, by contract, okay. Now that actually used to be the way healthcare worked when I started in healthcare in 1982. Very few contracts are built like that today, okay, but there are some. So for example, we do not have contracts with a lot of our payers, okay, because we didn't like the rates, so we're uncontracted. So if somebody comes in through an ambulance and goes into the emergency department, as they happens very often, do all this stuff, there'll be a charge for probably somewhere between $100,000 and $200,000, depending on what happens, maybe more. And because we're uncontracted, we can go to the payer and say, give us our billed charges. Now, they usually don't pay 100%, but it's usually like 90%, which is pretty good money, okay? So it's really good to be able to get paid on charges. So we like that a lot. How do you think the payers feel about that? Not so much, not so much. Okay, but that's the way it works. So you have gross charges, you have this rate, and so examples are uncontracted payers, trauma, et cetera. Okay, then we have something called per diems or per day. And I'm not meaning to ignore outpatient, but I'm trying to simplify things and just say, let's assume we're talking about inpatient revenue for everything, okay, to make it work. So a lot of contracts were then paid on per patient day, all right? So what is a patient day? It's a patient staying overnight in the hospital in a bed, right? That's one day. One patient, one bed, one day. And so what happens there is you typically negotiate a daily rate. Okay, so like with Medi-Cal, Medi-Cal typically, Medi-Cal traditional pays us with a daily rate. So they add up however many Medi-Cal days were there, as long as they were, you know, medically justified. Send in a bill, they say, okay, you get paid $6,000 a day. Here you go. Work it out. Pretty simple. Then we have something called DRGs. Anybody hear of a DRG? A diagnosis-related group. Okay, so what that's doing is it's looking at the types of patients who come into the hospital, and they're classified according to their disease or whatever's going on with them. So there's about 690 different classifications, like, oh, you're having a knee replacement, or you're having a heart surgery, or you're having a baby. Those are all different DRGs. This was a program that was implemented by Medicare, and this is how Medicare typically pays today. And the advantage is it kind of ignores how long the patient stays. Okay, so it's really not Medicare's problem if we're inefficient at moving the patients through the system, because they're going to pay the same for, you know, a knee replacement, whether the patient's here 2 days or 20 days. They don't really care, okay, generally. Now, a lot of other payers have liked that too, because in commercial plans looked at what Medicare did and said, oh, okay, that makes sense. We're going to do the same thing. Then there's things like per visits. Now, these are ambulatory, but so I put these in here because this is what happens with the FQHCs. So when a patient goes into one of our ambulatory clinics, which is a federally qualified health center, we get paid for the visit, okay? And it's sort of an all-in rate, so if they get lab tests or x-rays or whatever, they put it all together. But we get paid somewhere between $275 and $300 for an FQHC visit, okay? What about physicians? How do they get paid? They get paid on something called work RVUs, relative value unit. That's very similar to a DRG, except it's for physicians. And what they do there is they look at the types of things that a physician will do, and they have a coding system, like a 99211 is a basic primary care visit. The value assigned to that is 1, okay, and then everything else goes from there. So that's a basic visit. A 99212 is more of a complicated visit, so it might be worth 1.2 points. A surgery might be worth 8 or 10, okay? So that's their units, the volume. And then what happens is they have a conversion rate, and you negotiate that. And it's typically, with a payer, somewhere between $80 and $120, depending on how strong your negotiating leverage is. You can also pay a physician that way. So one way to pay a physician is say, well, how many RVUs do you generate, and give them a portion of the revenue that we generate. Now, they don't get all of it because we have costs to allow them to practice here. Okay, then you can have a fixed contract, all right, where you just say, we're going to do something for you, and you're just going to give us a big block of money, okay? Health Pack is like that. So Health Pack, so the county has a legal obligation to take care of the uninsured. They have said to us, we would like you to do that for us. We don't know how many there are, and it could change, or what their needs are going to be, but we're going to give you a block of money up front. Last year was 35, or the year we're in, it was like $35 million. Next year it's going to be $36.2 million. Okay, fixed. Whatever happens to that population, it's our problem. Okay, then you have something called capitation. Okay, capitation is taking financial risk for blocks of population. Actually, it's very similar to a fixed contract, but in this case, it says the units are going to be something called an enrolled life. So that is a person who has signed up with a health plan. Okay, that's one person. If the person brings their family with them, you get to count those people too. Okay? All right? And then what happens is the contract says, okay, we're going to pay you the number of people who've signed up for insurance times this rate that's called PMPM, per member per month. And that varies by the type of person, because say you're a Medi-Cal population, have a lot of young moms and babies, okay? They need some care, but not as much as a Medicare population. So typically, the Medi-Cal PMPM is about $80. So one person, if we have one person enrolled, we get paid $80 by Medi-Cal. That doesn't seem like very much, but not everybody needs health care every month. So if you have 10,000 Medi-Cal enrollees, you know, getting paid 80 times 10,000, that's $800,000 a month. Well, that's enough to manage a program. Okay, if you're a Medicare recipient, you might get paid $800 per month. Okay, like 10 times. Why? Well, because Medicare are elderly, they typically have a higher utilization rate. They need more health care. And when they do, it's typically more complex. Okay? Then you have supplemental reimbursement, which we're going to talk about next. And then we have county support in our case, because we're a designated public hospital. So one of the advantages of that is we get county support. And in this county, the county's passed a measure called Measure A, which says we get 3/4 of a 0.5% sales tax. Okay? 3/4 of 0.5% doesn't sound like much. This year it's $105 million. Next year it's going to be $108 million. Okay? So that's a lot of money. And then finally, philanthropy. Okay, so we are considered to be a tax-exempt organization, so if people give us money, they can deduct it on their tax return and get a tax benefit. So we can have that kind of money. So there's 11 different types of revenue that we get, okay? All right, we'll come back to that. A little confusing. I think the thing to keep in mind, though, and I had a slide in here that I took it out, but it said, you know, the real problem with incentives is that they work, is that all of these things are designed to provide incentives to organizations to change their behavior. Okay, so like in the 1966, I was only 12 in 66, but so I don't remember this exactly, but it's been quoted that when they were debating, the Senate was debating whether to pass the Medicare Act, which created Medicare and Medi-Cal, they said, we have a national crisis. We're only spending 7% of the gross national product on health care. That's criminal. It should be 12 or more, okay? So they passed this act. And they put in place basically this percentage. It was even worse than that. It was based on cost. It was hospitals, you know, go take care of these patients, figure out what your cost was, tell us and we'll pay you, okay? And then that went on for a few years, and guess what happened? The cost of health care increased, because if you're running a hospital, you just said, okay, well, let's figure out what the government's going to pay for and let's do it because we'll get more money, okay? That went on till about 1982 when they said, we have a national crisis. We're spending 12% of our GNP on health care, okay? We've got to do something. So they started changing the system, and Medicare put in this, okay, which is cost per discharge. So they said, we're no longer going to pay you no matter how many days you do, because you're just running up the charges, we're going to give you an incentive to be more cost efficient. Okay, they did that.
It's kind of when all the outpatient surgery centers started popping in.
Yeah, because it said, oh, okay, well, you're going to get paid based on the number of things you do. So what are we going to do? We're going to do more things, you know. Yeah, and actually surgery centers are APCs, but same principle as this, APCs. And then that went on for a while, and then they said, well, you know, now we're paying 16% of the GNP on healthcare. So what are we going to do? Well, we're going to pass the HMO Act, which was here in 1992. And what that says, we're going to create these health maintenance organizations, and they're going to enter into risk-based contracts so that they have an incentive to control costs more, and we're still living with that, and on and on and on. Okay, so let's digress, and let's talk about this number. Okay, that 26 million a month, okay? So that number, we're going to come back to this, don't worry. Okay, so supplemental reimbursement. So let's see, in 2016, this says 340 million. That's counting, don't worry about the math, I'll skip to that, skip on. Okay, here's what I want you to know. Supplemental reimbursement can be categorized into different areas. So county and city support, the Medi-Cal waiver, what we call supplementals, other, and incentive-based programs. And this is how much they've totaled up, okay? Now you can see they used to be pretty high, 338, 355, but they've been coming down. We're over here at 318, and next year 304, okay? And the real problem we have is this stuff, the Medi-Cal waiver. Here's the waiver. Boom, 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 gone. 2021, gone. Medi-Cal waiver's gone, okay? So one problem we have as a an organization is, well, how are we going to deal with that loss? And that loss is about $120 million. That's a big loss. That's a big hole to fill. It's going to start declining this year, actually, but then it's going to drop off the cliff. So we'll come back to how to solve that problem in a minute. But let's just try to understand all these numbers first. Okay, so here are the county and city programs. So first thing is we mentioned Health Pack. And I mentioned, now that used to be $100 million. And now it's way down. It's going to be $36 million next year. I didn't update the slide. Why do you think that came down? And I'll give you a clue, because that cost was to pay us to take care of the uninsured. So what happened right here? Affordable Care Act. Uninsured had health insurance. They qualified for Medi-Cal. So the county said, well, wait a minute, you're going to be getting these funds from the state for Medi-Cal, so we're going to reduce the payment to you, which is what happened. Here's the Measure A we talked about. Now these numbers, actually, we're doing better than this. So this will be 105 and that'll be 108. We get a subsidy for trauma, for the trauma program, EMS funding. We had a little bit of money to take over San Leandro. And we get an ongoing parcel tax from the Alameda Healthcare District to help us operate Alameda Hospital of $5 million a year. Okay? So those are county and city programs. Here's the detail on the Medi-Cal waiver. So the waiver is actually now broken into two parts. The blue is called GPP, which is a volume-based program. Basically, we get points for providing services to the uninsured. And then Prime, which replaces DSRIP, is down here, and we get points there for hitting certain quality metrics. So volume, access, and quality. So those are the incentives that are being provided. And this money is now at risk. Okay, so if we don't hit these targets, we potentially could lose this money. Change in incentives. Before it was a block grant. Okay, so but now the federal government is saying, okay, we're going to give you this money for 5 more years, but you've got to earn it. We want you to We want you to restructure your delivery system so that you can operate in a managed care environment. Okay, and to do that, you have to demonstrate that you can provide access by providing services, and you've got to demonstrate that you can achieve quality metrics. Okay, that's value. Cost and benefit, you know, in terms of quality, is value. So the government's saying, we want to make sure we're getting value for our money that we're giving you, and we want you to restructure. Okay, and that's what this kind of goes through. Okay, supplemental programs. These are various programs that look at our costs and say that, you know, we know you're not getting paid for the full cost of care, because a lot of these programs don't pay full cost. So they'll come in with these programs and they'll look at various components, whether it's you know, the managed care, newly eligible, traditional Medi-Cal, and they'll say, we're going to have this program, we're going to give you a little bit more money. Okay, and that's what all these things do here. So this year, about 40 million, next year about 29 million. Okay? We're not going to go through all the individual programs. You just need to know there's a bunch of them, but they're all doing the same thing. They're saying, what is your cost? What is your uncompensated cost? And we'll give you a little bit more money to cover that for various categories of patients. And then there's this thing called AB 85 realignment. Okay, so it used to be that the state gave the county that money that they gave to us under Health PAC to take care of the uninsured. And then healthcare reform came along and said, wait a minute, these people are going to be paid by Medi-Cal. The state's going to be paying that money. So we want to reduce the support for the uninsured that comes from the state to the county. Okay, so the state reduced that payment and the county reduced it to us. But then they said, well, and this was their argument, so you no longer have to pay for free care for the newly eligible, so we're gonna take that money back. Okay, and there's a calculation to estimate that, but then there's kind of a true up after the fact to say, well, what really happened? Did you still have unreimbursed costs? Okay, and if there was, the state will come in and they will give the county more money, and the county will give us more money. Okay, in addition, the state also on the Medi-Cal program has said, you know, the state's contracting with all these health plans to provide Medi-Cal. Like they contract with Alameda Alliance, they give them a bunch of money. Alliance goes out, contracts with everybody they need to, including us, but also including Sutter and you know, other places. So they said, well, you know, the state is authorized by law. There's a max on what they can pay the health plans, but typically they pay less than that. Okay, so there's this amount that the state holds back. Then they said, well, but we want, regardless of all that, we want to make sure that at the end of the day, when the Alliance contracts with Alameda Health System, since you're a designated public hospital, that you get your cost. So there's a calculation under AB 85 that says, regardless of all this other stuff, at the end of the day, we're going to come in and write you a check if you haven't got your cost, assuming 2 or 3 other things have happened or haven't happened. Okay, so that's a good thing. So that's called the AB 85 cost guarantee, which is really important to us. So that was actually brought in an extra $70 million this year. So it's a big deal. Okay. All right. Then there's AB. Now this is another supplemental, and again, it's saying, okay, if you didn't get your cost on skilled nursing, we're going to come in and give you some extra money there. So these are all calculations that get done by what's called our reimbursement department in what's called the P14 cost report. This is the cost guarantee I just mentioned. So that's supplemental. So what you need to know is it's a lot of money. It's like 3/9 or third of our budget, but it's going to go smaller. And our problem is, what do we do to replace that lost income? How do we make it? Because if we had to lose $100 million or $120 million tomorrow, that would be, that'd be a problem. Okay, but we have 5 years, right? Okay, so let's talk about that. Now we're going to back up. Okay, so everybody remember this discussion, right? So does everybody kind of get the concept of volume times rate equals revenue? And there's different kinds. And so we're going to, and of course we have all of these. We're not like all in one basket. We have eggs all over the place. So it's really kind of schizophrenic, because the way you want to behave is a little different depending on, what kind of contract you have. But of course, we don't put, tags on people's heads and say, well, you're Medicare and you're Medi-Cal, and everybody gets the same care, right? Okay. So, but we have to sort our way through this, and that's what we're going to do next. So, let's look at HS right now. Okay, and I've simplified this. This is a very simple income statement, sort of in that break-even format. Remember that from last time? Okay. So let's just walk through this. So, do you remember when we said we had $48 million of monthly revenue and $26 million of supplemental revenue, and that was $74 million? Okay. And do you remember last week when we said we have, some fixed costs, which I'm estimating at $40 million, and some variable costs? Okay. All right. So then I said, well, let's look at what some of the volumes are here. And so I know that we have about 8,000 patient days a month. Okay, which is about 260 people in beds at any one time. Okay, 260 average daily census. Okay, that's an important number, and we'll come back to it. I want you to remember that. And I know that we have about 1,600 discharges. Now, what's the difference between a discharge and a patient day? Okay.
Discharge may not have stayed overnight, so they don't count as a patient.
No, a discharge is one inpatient admission, regardless of how long they stayed. They could stay 2 days, they could stay 10 days, 20 days. We have some patients who stay 360 or more, okay? But we divide those two. We take patient days and divide by the discharges. And we come up with a number called the average length of stay, ALOS, okay? And in our case, for acute patients, it's about 5. Okay, so if you take 1,600 times 5, that's 8,000, or you take 8,000 divided by 1,600, that's 5. All right? Okay. So I'm setting a framework here for what we're going to go through, so it's important that I get you grounded on how this is working. And then I said, well, about how many people, if we were capitated, how many people would that be? Okay, and we're not actually capitated, so I had to make an estimate. So I said, well, what if what's called the use rate was about 120 admissions per 1,000 people every year? Okay? How many people would that be? And it works out to 160,000. All right? So 160,000 times 120 divided by 12, because we only have 1 month. So that's usually 120. So if you had 160,000 people, you could expect you could expect 1,600 hospital admissions in a year, in a month. All right? So in 12 times, that would be whatever that is. Does everybody get that, or is that too confusing? Okay. Yeah, so this is a common measure in the insurance industry. So in insurance, what you do is say, we're going to take the risk, the financial risk for, say, 100,000 people, all right? And so then one of the things we have to do is estimate what our cost is going to be, okay? So how much health care are these people going to need, these 100,000 people? Okay, and it varies whether it's Medicare or Medi-Cal or anything, but let's say an average use rate is 120. So 120 per 1,000 people. So there's 100,000 people. So 100 times 120 is 12,000. Okay, so it'd be 12,000. For 100,000 people, you would expect to see 12,000 hospital admissions in a year. Okay? And the insurance industry uses that to estimate, to do their budgets. That's how they do their budgets. Different than the way we do our budget. Okay? All right, but assuming that it's this way, 106,000 people, use rate's 120, so there's 1,600 discharges, they stay an average of 5 days, then that's 8,000 patient days a month. If our charges per day are about 30,000, which is about what it is, believe it or not, then that's 240 million of gross charges a month. But remember that collection ratio? We only collect 20%. So we collect 48 million. Does everybody see how that, all the math works all the way down to there? That and that. Okay, now let's look at it from the different point of view. So let's say all of our contracts are percentage charge. Okay, so we have, here's our charges, 240 million. Okay, and we have one contract, and the contract says whatever your charges are, we'll pay you 20%. Okay, so we would get 240 million times 20, 48 million. Okay, that's one example. Now, what if instead of that we had a contract that said, you know, we're not going to pay you on charges, but we'll pay you on days. And so you have 8,000 days, we'll pay you $6,000 a day. And that's $48 million, same thing, right? Okay. Or we're not going to pay you on days, we're going to pay you on discharges, DRGs. Well, you have 1,600 of those, we'll pay you $30,000 a discharge. $48 million. Or just capitate. Just take responsibility for all of those people. We'll pay you $300 per person per month. And the rest of it's your problem. Okay? $48 million. So far everything's the same. 74, 74, 74. Here's our cost, 72. We're making a little bit of money, 4%. Everybody's happy, right? Okay. That's to start. Now let's start playing with this a little bit, all right? Do some scenario. This is called scenario analysis, okay? I'll do a real easy one. Okay, let's say we grow. We have more patients, all right? Let's say we have 20% more patients. So instead of 160,000, we have 192. We have the same use rate. So now we have 1,920 discharges. Okay, that's more than 1,600, 20% more. Same length of stay, but we have more patient days, right? More discharges, more patient days. More patient days, more charges. Look, charges have gone up, 288 million. We get paid 20%, 57.6, that's more than that, right? So we've grown, more revenue, total. Wait a minute, expenses went up. Why did expenses go up? More patient days, variable cost. But, hey, our total profits went up. That's cool, okay? Same thing happens over here. Why do we get more revenue here? Well, we have more days, per diems. More discharges, more revenue, more enrollment, more revenue. Same. So again, same. More volume, better. Everybody's making more money. Okay, that looks good, right? Okay. Now, let's ask this. What happens if we have a capacity constraint? What is a capacity constraint?
Can't take any more volume.
You can't, right. So how many, if you look at these days, how many is that? 260, I said, right? 260 average daily census. How many is that? About 320. How many beds do we have? Not that much. So we can't actually do that, can we? That's called a capacity constraint. So we're actually pretty full as a system. If you just look at acute care beds, we're pretty full. So that's a problem. Okay.
But couldn't we achieve a similar outcome if we were to reduce our length of stay?
You could. You could. Exactly. Okay. So let's look at some scenarios. So in here I said, well, actually let's increase the length of stay. What would happen if for some reason the length of stay increased? Okay, but let's look at this. So length of stay increases. So here, length of stay increases, so now we have 9,600 days, right? We're still getting paid off charges, so we have 57.6 million. 5.2, just like before. Remember the other one? 5.2. So here, we actually had more enrollment, but here we don't. We just have the same number of patients, but they're just staying longer. Okay, but if you're getting paid on charges, you don't really care, right? It's cool. And if you're getting paid on a daily rate, you don't care because you still get paid. What if you get paid on discharges? You care. All of a sudden, oh my gosh, we're losing money. Oh my gosh, that's not good, right? And if you're enrolled or you have a capitation, you don't like it. You're losing money because their revenue didn't change because they don't get paid based on charges. They don't get paid on patient days. It's on discharges or enrollment, okay? That's a problem. Okay. Now, we still have a problem because that's still 320 patients. And we don't have the capacity to do that. We have about 300 at most. Okay. All right. So, that's your question. What would happen, do you think, if the average length of stay, instead of increasing, decreased? What would happen?
I guess the percent of charges and per diem, we would potentially lose money.
Yeah, because on these two folks would lose 20% of their revenue. Now their expenses would come down a little bit, but not enough, and they'd actually look just like this. How would these two guys look? They'd look like this, because in their case, their revenue wouldn't change. Same number of enrollment, same number of discharges, and the costs go down. Found money. Terrific. Get the length of stay down. Okay. Now, what would happen if the utilization rate, that's this number, discharges per 1,000, went down by 25%? And just to give you some information, the commercial, in California, the commercial use rate is about 75 for California, for commercial patients. For Medi-Cal, it's less. For Medicare, it's more. So if we looked at our population and say, well, there's a lot of overutilization going on, we're going to maybe invest in care coordination and population health management and expanding access and maybe try to keep people out of the hospital, okay? So it's actually possible to reduce the use rate, but let's look at what would happen here. So we'd have same enrollment, so their revenue is 48 million, it's going to stay the same, okay? But we're going to have less discharges because the use rate's down. So fewer people being admitted to the hospital. So that's down to 1,200, so their revenue is going to drop, in this case by $12 million, big drop. We also have, assuming the same length of stay, fewer patient days, fewer charges, and so their revenue drops as well, okay? So what's occurred here? So, and the expenses are down somewhat, but not enough. So now they're losing money, these three. Who's making money? The insurance company, okay? Insurance company's making money. All right, now let's go crazy and do a multivariable scenario analysis. What does that mean? Multivariable. Changes more than one thing. Let's throw a bunch of assumptions in here, in this model, and see what happens. Okay? Closer to real life, yeah. Okay. So let's say, let's look at our constraint. So our constraint is this number, 8,000, which is sort of like our functional capacity, because if we have 300 beds, we have a capacity, assuming 30 days a month, of 9,000 patient days if we have every bed filled every evening, which doesn't typically happen, does it? Because for a couple of reasons. One is you can't always fill all the beds because you've got restrictions. The other thing is patients don't come in on a uniform flow. Okay, they go like this. They spike up and down. And so the functional capacity of a hospital is usually 80 to 90% of the beds. Okay, so if you have a theoretical capacity of 9,000, you multiply that by 0.8, that's 7,200. We're actually over that. 90% would be 9 times 8, 8,100. So which is about where we are, right? Okay, but if we could find a way to get our revenue up but keep the days down or even reduce them, that would be good, right? So let's see. So we get our enrolled lives up to 192. But we get the use rate down to 90, which we talked about. So now we have 1,440 discharges. That's less than that. And we also get our length of stay down. Then we only have 5,760 days, which is under 200. Way less than the number of beds we have, right? So we could actually look at, converting those to subacute care or something, or grow more lives. So what we've done here is we've created more capacity under this model, because now we could probably insure 250,000 and still have enough capacity to take care of it. Okay. But so what happens here? So we have fewer discharges, fewer days, way less gross revenue. So our net patient revenues dropped from 48 down to 34. Same thing's happened here because we get paid per diems. Here, not quite as bad because we get paid off discharges. They're not taking the effect of the reduced length of stay because you get paid on a discharge basis. But look at these folks, 57.6. They're printing money at that point. They're an ATM machine, right? Okay, so if you're, let's see, the rest of these people though are not doing so well. These people are surviving, but this is losing money over here. So let's see. So if you're in an environment where the government is going to pay you your costs or charges, whatever happens, where do you want to be up here? Do you want to have your contracts be percent of charges, per diems, DRGs, capitation?
They're going to pay us on percent of charges?
You have it your choice. So let's say, but you're going to get, well, let me drive the question another way. Let's say you're in an environment where utilization is coming down. So there's been overutilization of services, so there's going to be fewer inpatient admissions, there's going to be fewer patient days, and fewer charges. Okay? And if you're an insurance company, how does that look to you? Pretty good. Life is good. Okay. Let's say you are an academic hospital, like either UCSF or a teaching program like we have here. You have high costs that are largely fixed. Okay, so you can't easily get your costs down. And use rates are dropping, so you're seeing fewer and fewer patients come into the hospital. Okay, and your contracts are largely percent of charges. What does your life look like? Not so good. Not so good, because your revenue is disappearing, but you can't adjust your costs because most of them are fixed, and even the variable ones are subject to union agreements. So you can't just come in and reduce benefits or do layoffs or anything. So world doesn't really look very good to you, right? So if you're a well-capitalized health system who's been used to, you know, sort of dominating the market, like a UC or Stanford or John Muir, and you're seeing your margins deteriorate, okay, and then you're looking across the street at Blue Cross in Walnut Creek, nice building, and they're printing money, what are you thinking? This is not this. We want to change this. We want to change the picture here. And so what these plans are now doing is they're saying, okay, well, we want to move up the food chain. Okay, the food chain is this. That's the top of the food chain, and it works its way down. Okay, and to move up the food chain, they're saying, okay, we want to be in the insurance business. We want to fix our revenue, get paid a percentage of this capitation. We will then take responsibility for managing the care and driving utilization down, and we will also realize the benefits of doing that. So we'll get to keep the money. Okay, so rather than seeing our top line deteriorate, they'll fix it, and then as utilization rates come down, they can profit that way. And then they say to the insurance company, you're really just there to do marketing. Okay, so, and you're not taking risk anymore, so we're going to transfer, there's something in insurance called the risk premium, which is an amount of money you pay somebody. It's like paying insurance, like we have property insurance on the building. It's property, the hospital's probably not going to fall down next year, but we're going to pay a risk premium to somebody. In case it does, they'll step in and build this new hospital, right? Okay. Same thing here. There's an amount of money that's typically about 4% of the total revenue that goes to the organization that accepts risk. Okay? And that can move back and forth. Okay, so let's then, everybody follow this so far? It's kind of,
So are most of them going to the capitation now? Is that what you see with all the groups going together?
yes,
They assume the risk, so that's the reason there's a big push for preventative health care and all that.
Yes.
To keep them out of the hospital?
Yes.
That's what they're looking at?
yes.
Okay, that makes sense then.
Yeah, believe it or not, it is not pure altruism that they're doing that. Okay. All right, now let's look at us. Okay, so here's back to that first slide. So this is us currently. So we've got about 74 million, and maybe we're making, 2 million a month, or about 4%. All right? Now, the problem is right here. So we're getting 26 million a month. In 5 years, that's going to be about 10 million a month. Okay, so that's a loss of 16 million. And I think somebody in one of the classes said, well, how are you going to make that up? What's the plan? Okay, so, and this isn't exactly the plan, but it's a sample plan. So this is what could happen. We could say, okay, we're doing about 8,000 patient days. So we're really at functional capacity, which is 8,100. So we can't take too many more patients. But if we could reduce our length of stay, say from 5 to 4.5, that would be, and if we could do that, that would increase capacity. And if we were to capitate for these lives, in other words, capitate means signing a contract to take financial risk to provide health care to those patients. And if we could improve our utilization, say we get a 10% improvement in utilization, which is possible, then we could actually capitate for about 192,000 lives. Okay, and one question is, are there that many lives that we could capitate for in this county? The answer is yes, there actually are. Yeah, oh yeah.
Even outside of Kaiser, there's still that many left?
Yeah.
And what's the most accurate source of that data?
This is just a pro forma.
No, I'm
This is
saying
just,
if you were trying to do an estimate on how many potential lives you could
yes, okay. There are lots of databases we can get that information from. We have a whole planning department. We have access to how many people are here, their demographics, what insurance they have, where they're currently going for health care by zip code. We can go to the Alameda Alliance. We know how many enrollees they have, where they're going, everything. Okay, so, but let's assume for this purpose that we can do that. Okay, and then let's assume we, instead of getting paid on charges, we're getting paid on capitation. And let's say we do a good job negotiating rates. So we get this up to about 330. Okay, so now our revenue, patient revenue, goes from 48 to 63. This goes down, but we have about the same revenue. Okay, and since we've reduced patient days a little bit, we get a little bit of a break here. Maybe we come in and address our fixed cost problem, okay, which you can do over time. And so now we can make money. So in this case, $9 million a month. So, yeah.
Well, I'm trying to understand it. So if our length of stay went down,
Yeah.
they're staying less days, how does that affect the cost per day? It seems to me like no matter how many days you're here, your cost for a day is gonna stay the same. Does that, I feel like I missed something.
Well, there's variable cost per day, and then there's fixed costs, which don't change, okay? And then it's not just a function of cost per day, it's a function of cost per discharge, okay? So remember, from their vantage point, from the vantage point here, it's what do they have to pay for to cover an enrolled life or to pay for a discharge, okay? So if you reduce utilization, so the patient never shows up here, that's a cost savings. That goes to the bottom line. If you reduce the length of stay, that's a cost savings.
And I get that. I'm just looking at that line 12, the cost per day.
Yeah.
So that's all calculated in that 10% reduction.
Well, what I just assumed is that, you know, we did something here that we were more efficient.
Okay.
Let's say we put in some type of, we're staffing better, we've somehow improved our benefit costs, we've done something to reduce the variable cost per day, and we've also come in and we've done something to reduce our, you know, ongoing, you know, fixed costs. Okay. I'm just saying, you know, this would be a comprehensive strategy to survive without the Medi-Cal waiver money. So it would be something like this.
Where do we stand as far as the community average for length of stay? Is the 5 comparable or?
No, 5 is actually pretty good. The problem is, and this is a gross simplification, we have you know, all kinds of different patients, and we also have psych patients and rehab patients, which are in that number. So you really need to break it out by facility to see where we are. But my perception is we're probably higher than, there's probably opportunity to reduce the length of stay in the system, just from what we've seen. Okay. Okay. So we just have one more small section to do. So we're doing pretty well. Do we need to go back through any of this? Do you have questions about any of this? Do you kind of get it, how you would survive in a competitive environment?
Well, I do have a question, but I'm not sure how
Yeah.
even to ask it. But
Yeah.
just thinking about all of the things that I've heard, and again, some of these may not be true or accurate, but it seems like being an academic center and a level 1 trauma center, I've heard that we will frequently admit patients, maybe not because they need to be admitted as much as we have to admit a certain percentage to keep our trauma rating, which I assume then relates to how much money we get from certain organizations or Medicare or something. Center, and then also the academic, I've heard that we admit them and keep them longer so that we provide the training environment that the residents need.
Yeah, I mean, I hadn't heard that. I mean, I think we have, the good reason to have a teaching program here is there's plenty of volume coming in all the time, and as you can see, the building's generally full of patients. So I've never heard that, and nor would I expect to, because that wouldn't be appropriate.
That's not true, but it just,
Yeah.
I've seen some
Yeah.
things that make me feel like perhaps some of it.
Well, I mean, the
But I
thing is,
relate.
you know, I mean, all these cases get reviewed. you know. And if we were to bring in a case that really didn't need to be here, we would hear about it from a payer. And so those kind of reviews go on all the time. So I'd be surprised if that was actually the case.
Good.
So, yeah, okay. Okay, let's see. So we did this part. So now I want to talk a little bit more about capitation. Okay. And sort of what we would need to do, because the conclusion of the other part was, you really need to think, convert to a capitated model, improve utilization so that we have more capacity, and then that'll expand our revenue base. Okay. So this is sort of a more detailed example of how capitation works and how the incentives sort of drive improved utilization. Okay? So let's see. How do I do this? So you've heard the term follow the money, right? And that's sort of what capitation's all about. It's about creating incentives to drive behaviors. And I've been in healthcare a long time, and I always look back and people would say, oh, we're not, meet with physicians, oh, we're not financially driven at all. We're completely, it's just whatever's for the good of the patient. I go, well, okay. But I mean, from what I've seen, everything's completely financially driven, pretty much. So here's how this works. So in capitation, there's something called a division of financial responsibility, called a DOFR, D-O-F-R, Division of Financial Responsibility. And what that does, well, the first thing that happens is the health plan writes an insurance product. And the insurance product has to be approved by a state agency called the Department of Managed Healthcare. It supervises all of these health insurance plans, okay? And the insurance contract says, basically, here are the benefits that we're going to provide to you, and here's the cost. This is what we're going to sell the product to you for. So if a member, an enrollee, signs that contract and pays a certain amount of money a month, he gets a card. You all have a card. That card allows you to access your benefits, okay? And your benefits are, you can go to a primary care physician, you can go to a specialist, you can go to the ED, you can get admitted, you can do all kinds of different things, okay? Some things you can't do. Can't go get a massage, can't go to a spa, okay? But there are certain things that are in that, the benefit list that says this is the product. This is what you're selling. So that's what the insurance company has. Now, at that point, the insurance company has the risk, okay? So they're completely obligated. Now, the problem the insurance company has is they don't actually provide health care. Okay, they don't run hospitals, they generally don't run doctors, except for Kaiser, exception, okay? So they have to, they have the legal obligation to demonstrate to the Department of Managed Healthcare that they can, in fact, deliver all of the services that they said they could provide for anybody who purchases those policies. Okay, now the way they do that is they contract. Okay, in the old days, they'd sign contracts with all the hospitals on a percent of charges, blah, blah, blah. But as things have developed, organizations like us and UC and John Muir have gone to them and said, wait a minute, we want to move up the food chain. We want to capitate. So we will take financial risk from you, okay? And in exchange for that, we want what? The risk premium. We want to take 80% of the risk, then we want 80% of the risk premium. Okay, we want to take that extra 4 or 6%. We want that money, okay? So typically what happens is a health system like us would approach a plan like the Alameda Alliance, okay, or a new company that's just starting called Canopy Health, which is the UCSF, John Muir, blah, 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 new health plan that's going to start August 1st. And we say, okay, we want to capitate, all right? So how do you capitate? Well, the first thing is health plans look at hospitals different from providers, physicians. Okay. Now, between hospitals and physicians, who do you think has the most impact on the cost of care? The physician. Yeah. Because how many of you write orders? Nobody, right? Physicians write orders. Okay. Physicians typically aren't employees. They can be. But typically, the physicians act as a group, and they're the ones who control the cost. Okay. So what generally happens is the health plan says, okay, to the doctors, we're going to pay you a cap rate, a certain amount of money per member per month, to provide professional services, but then we're going to give you some incentives, okay? So we're going to say, okay, those hospital costs over there, we're capping them too, but to the extent that hospital costs come in lower than budget, we're going to take some of that money and give it to you, okay? So if you reduce length of stay, if you don't do a CT, if you don't do a procedure, there's going to be savings, and you can have some of that money. How do you think physicians react to that? Very well. Yeah, it's like, oh, well, all that stuff is really inappropriate anyway, and then we're going to improve patient care by not doing that service and get paid for it, okay? So that's that risk sharing. And so, anyway, so there'll be a hospital risk pool, and then they'll have an agreement with, in this case, Alameda Hospital or Highland, all the different hospitals be under the hospital side. On the pro side, they will contract with what it says Alameda, which is Alameda Health Partners. But the other thing they can do is they can contract with unaligned providers in the community. Let's say they need somebody to do oncology, and let's say we don't have an oncologist. Well, we can go contract with somebody, get them in there, okay? Pay them on a cap or pay them fee for service, doesn't matter, okay? So is everybody kind of getting how capitation works? All right. Okay, let's see. I just have a couple more slides here. This is like a very, very summarized DOFR, Division of Financial Responsibility. And what it does is it's sort of talking about typically what the hospital would, or what the hospital would do over here, and what would the medical group would, not what they do, but what they'd be financially responsible for. Okay. Now, when you actually do this, a real DOFR is generally about 5 pages, and it lists every single thing that could happen to a patient and says who is going to take the financial risk to provide those services. And then they quantify that by taking the premium and divide it up into pennies and say this is, emergency room coverage is worth this. Primary care service is worth that. Whatever it is, all the way down by specialty, boom, 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 boom. So you know exactly how the premium dollar is going to get split up between all these parties. But, so for example, a medical group, they typically have inpatient physician services, outpatient, allied health, PTOT, speech, radiology professional technical, lab, okay? Then there's some things they might get paid fee for service for, not capped, but transplants. So why would you do this? Well, because there's not enough volume here to make it a predictable, predictable cost. And if it's not predictable, then you really can't cap it, because it's, you get paid pennies, and then you'll have one event, and which is huge, and then somebody goes out of business. So something gets paid fee for service. Look at this. They typically get paid emergency out of service. So if an enrollee has to go out of the service area and get emergency care, that comes out of the doctor's pocket. So that gives them an incentive to get on the phone, manage the care from afar, get them repatriated if possible. You know, basically keep them out of the ED. Okay? They get a bonus potential. So if the hospital does better over here, they get part of the money. And they typically divide that up at the physician level. So it would come down not just to the group, but an individual physician gets, you know, a financial incentive for a good outcome. They also get an upside on retail pharmacy. So this is typically, this cost is typically borne by the health plan over here, retail pharmacy. But they're saying if our budget for retail comes in under, if our costs come in under budget, we're going to give you some of that money. Why would they do that? Because doctors order the drugs, right? Okay, makes sense. Hospital, obviously the hospital care, inpatient, outpatient, DME, home health, infusion, ambulance, dialysis. Okay, and then sometimes they get paid fee for service for these specialty services here. And then they can get a risk share too. So if the, and typically the risk share comes out of the hospital's cost, but they take 10% of it, put it over here and say if there's savings, the doctors get some, the hospital gets some, and sometimes the plan gets a little bit as well. Okay? And then typically the plan keeps things like this, retail, transplants, mental health. Okay? All right. I'm seeing some just overwhelmed looks. Okay. But this is just to kind of expose you to this world. Now, the problem we have is, so assuming we say, you know, the solution here is to convert to a capitated model, then we have to prepare to do that. And the question is, well, what do you need to do that, and are you ready? Okay? All right, so we had a assessment done. This is a real assessment of us. And the scale here is on the bottom, so that is you are not prepared at all, and that is you're perfectly ready to go. Okay? Well, these are the kind of things that you have to do to you know, essentially be an insurance product or run capitation. So you have to have a call center, which we don't have. You have to have some place where your patients can call and say, hey, I need service, where do I go? You got to be able to process claims. Can't really do that. Got to have a compliance function. Not really. Contract loading, no. Credentialing, we're pretty good. Got to be able to take documents in. We've got a lousy IT system. We're okay on eligibility, okay in finance. Okay. Got to have a grievance and appeal process. So if you're providing insurance and somebody says, I want to go get this service, and you say no, we're not going to let you do that, then you have to be able to run that through an appeal process. Obviously, you have to be able to contract. Well, we can do that. Have to have an IT infrastructure. Not for capitation. I mean, forget about the one we're using. Okay, for capitation, we have 0. Now, it just so happens that this company will do that for us. So that's why we're talking to them. Medical management, we're doing much better there. Provider contracting, we can do that. Provider relations, we can do that. Quality, got some work to do. Okay? And then this is the last slide. So this is just to say that as a health system, we're going to have to build some new competencies in order to survive in this new era. So these are the kinds of things that have to happen. You know, physician integration, building financial strength, because as an insurance company, you have to be financially strong. The reason is because you're taking financial risk. You could have a catastrophic event, costs could go out of control. You've got to have a balance sheet that you can use to meet those needs. And there are certain financial ratios that the Department of Managed Healthcare looks to say, you know, are you able actually to write a contract that says you'll take financial risk? We've got to improve here. We've got to look at risk absorption in a new way. Obviously, cost effectiveness. Service delivery system rationalization. What does that mean? What is that? What is that about? Okay, that means if we converted ourselves to a capitated model and we took financial responsibility for 200 to 250,000 lives, we could do predictive modeling, and we could say, based on our use rate, we know how many people need to go to the ED, how many admissions, how many heart surgeries we're going to do, how many joints we're going to do. We could predict all of that, okay? Then we'd say, well, okay, if that's the case, then how many hospital beds do we need, and where, and what kind of beds, okay? And how many providers do we need, and where? And do we need to have, you know, heart programs at different locations, or should we just put them all in one place? Okay, like look at Kaiser. What do? Do they have full service hospitals? No, they don't. They have community hospitals we can go to, and if you need specialty care, there's one place in the Bay Area you go to for specialty care. Okay, or whatever service regions they have. That's service rationalization. Obviously, IT to do this, care coordination, which we're doing now, and really the biggest thing is it's a complete cultural change. So change is hard. So, okay. All right, and this is kind of the intro for the next lesson, which I think is going to be about strategic planning, the last lesson. Okay. So that's it for today. Thank you.